All right, we're going to get started with our last panel. So this is the Realizing the Health Potential for Our Children. And after this panel, the doors will open up again, and we'll have a closing session, and we'll have a performance by grandmothers and granddaughters with some African drumming. And then we hope that you'll stay and all join us in a networking hour sponsored by United Way, where we have a little more time to talk with each other about all of the good things that I have been hearing today. So again, I'm Jill Korbin from the Schubert Center. And we're going to start the session by looking at a portion of the selfie videos that children from the wraparound schools did and that Samantha Hill from the Schubert Center worked on with sponsorship from United Way. So we'll start with that, and then I'll introduce the panel and we'll roll along. Can you guys hear in the back?
Staying fit as an athlete.
Exercise. Medicine. Eating fruits and vegetables.
Eating proper foods.
I enjoy doing mountain dancing.
Working out and playing football.
Dancing.
Okay, this is the portion of the videos, and these will be playing continuously in our networking hour. All right, so it's my pleasure to start off our Realizing Health Potential today by introducing our moderator, Terry Allan. Since 2004, Terry Allan has been the health commissioner at the Cuyahoga County Board of Health, watching over the health of more than 800,000 of us in 58 communities in Greater Cleveland communities. He's also an adjunct faculty member at Case Western Reserve University's School of Medicine and was a Year 13 scholar of the Centers for Disease Control's National Public Health Leadership Institute. Terry, he says that's plenty. It's not quite, I'm not quite through. Terry is also a past president of the Association of Ohio Health Commissioners and a past president of the National Association of County and City Health Officials. He earned his Master's of Public Health degree from the University of Hawaii, which I think is a notable fact that here we are in Cleveland. Today is beautiful, but we have suffered through a long, long April of not such good weather, but we still got him back from Hawaii, which is amazing. So bringing this really enormous expertise and long commitment to the health of Cleveland's population, we're in excellent hands today with Terry as the moderator of this panel. So thank you very much.
Thanks, Jill. By the way, I got back from Hawaii in 1994. I've been back a while, and I ran out of money. I had to come back. So that's a fact. To provide some context, first I'm going to tell a story. When I was growing up, I grew up off about 156 in Puritas, near the airport, if those familiar. We lived in a small house. There were 6 kids. And on occasion, we had a relative that had the guts to have us over for a holiday, Easter or something, whatever it may be. And so my mom would line us, 6 of us, up in front of we had one bathroom, so we'd line up in front of the bathroom. And we'd walk in and she would grab our face and she'd wet the comb and comb our hair and wash our face and say, sit down on the couch, because we would otherwise be outside or whatever. So this happened, and then we'd sit on the couch, sort of line up next to each other. So this happened for many years. So we're getting up in our teens and we're getting ready to go to a relative's house, and my brother Pat, I walked into our living room and he was in front of a mirror and getting ready to go, and he was combing his hair like this, like this. So I guess he thought that was really the only way to do it. And so for me, perhaps the analogy is that for all of us, I've learned that for, saying lately that, clinical medicine and public health were separated at birth. I would say the same in many ways with health and social services, and that we need to find, to recognize there's another way to do it. And this convergence is, I think this reunification is, we are amidst this reunification. I think that's very critical. We know that in the neighborhoods of the children that we all seek to help, is that the choices that folks make are often the choices that they have available to them. And the hyper-local context of the resources or lack of resources is very pronounced. And I know that all of you are very committed to this work. And I am very much, I feel very, very positive about the future because of this convergence. The discussion about structural racism and some of the history and realities and compounding disadvantages that these children are facing, and the need to deal with the stressors that precipitate those challenges, and the commitment in this room. For me, it's very motivating, and I appreciate that. So what we have the opportunity today is to hear from a whole range of experts that are going to talk to us about challenges around infant mortality, the social determinants of health, and ACE's work that many of you are familiar with, hearing about the importance of data and telling the story to chart our progress and understand the granularity of the challenges that we face, alternative forms of healing, meditation, and opportunities to think about yoga, mindfulness, different healing modalities. We'll also hear about telehealth, a new opportunity to connect with folks in a different way, and hear about what I love is this prevention warrior language around promoting health among LGBT youth. So we'll hear a whole range of discussions in this context. And so what we're going to do now is I want to prepare you. You have these table tents. If you haven't been in any previous sessions, you have to pull your URL there for the health session at the bottom to prepare your phone so that you can participate in our polling when we get halfway through here. So load it in your phone as we prepare for our discussion. So we're going to go through a series of speed dating 7-minute sessions with our panelists who are going to share their stories rapidly because they want to interact with you when the question and answer session begins. So that's the approach we're going to take here. So I have the honor of very quickly introducing, because their bios and information, long list of their what they do and how well they do it is in the program. But we have with us today Bernadette Kerrigan, who's the executive director of First Year Cleveland. We have Dr. Hollie McDavid, the medical director of child advocacy and protection at Rainbow. The first three speakers, and the last of the first three is Jean Frank, the manager of school-based surveillance and evaluation at the Prevention Research Center for Healthy Neighborhoods at CASE. And so we're going to go in reverse order. We're going to start with Bernie, and so I'll cede the podium to Bernadette Kerrigan.
Thank you, Toby. Good afternoon. First of all, I'd like to say happy anniversary to the Schubert Center and thank Jill, Gabriella, and Samantha. They gave First Year Cleveland a challenge, especially with me being their inaugural executive director, to stay within 7 minutes. So we actually created a video just for this opportunity. It is a work in progress. Literally, we are getting changes. We made changes just all of 24 hours ago. We are going to be making more changes. This is not for all audiences. I'm going to trust that we are being very bold at this moment. First Year Cleveland will have lots of information, but we've had decades, 5 decades of our babies dying, and we are on purpose today being disruptive with our data to give you our best thinking to sit and maybe look this at a different perspective. And we thank Terry's on our executive committee. Any input to this would be greatly appreciated because we're probably only about a week or two out of then releasing it with other material. Last but not least, we do have data, more data at my table if you'd like, but thank you for inviting us, and we appreciate you sitting with what we think is an important message.
That was Bernie's presentation. It spoke for itself. Thank you, Bernie. Lolly?
So I feel like I should get up and do my Tony Braxton rendition or something. I can't sing, or I would. So I'm Hollie McDavid, and I'm at Rainbow Babies and Children's, and I see a lot of people I know. You also got a handout from our Center for Child Health and Policy at Rainbow, and it's around ACEs in children in Cleveland. Dr. Sarah Ronis, who's sitting in the back, is one of my young colleagues who's going to really make a name for herself. And Bob Needleman is here, and we're going to talk about Health Leads. And Health Leads was actually started in Boston at Boston City Hospital by one of Bob's mentors, right? Yeah. So Health Leads is... it envisions a healthcare system that addresses all patients' basic resource needs as a standard part of quality care. So it's a mismatch between drivers of health and expending. As you can see, patients' lives outside the clinic drive a vast majority of health outcomes. You can see the numbers: access to care, genetics, socioeconomic, physical environments, healthy behaviors, interactions among determinants. And then when you look at what we spend our money on, we spend our money on medical services and some healthy behavior stuff like stop smoking. So what Dr. Barry Zuckerman at Boston City decided to do was to put together a program where they would look at their families and see what else they needed, what was keeping them from being healthy. And we got it at Rainbow because our chair of pediatric urology, he came to me and he said, you know, my daughter's been doing this in Boston. She's at Harvard, and all these kids from Boston do this, and we ought to bring it to Cleveland. So, yes. So urologist brought it to us. And I was hoping he was going to say his daughter was going to go to medical school and be a change agent, but she's actually going to law school and she's going to be a change agent. There are all kinds of ways to do it. So there's a suite of solutions that you can look at: education, planning and coaching for social needs programs, knowledge sharing, learning collaboratives with leading providers tackling social needs, consulting, tools, best practices, and data across diverse institutions, technology, purpose-built platforms to track patients and locate resources and manage workforce, and that's called Health Leads Reach. And then Health Leads implements social needs intervention to pattern with recognition and best practices, plus a network of clinical supporters. So we got in touch with them. They came to Cleveland. We started looking at what was out here because actually Taiji Hill, who is my co-author on this, she doesn't live here. She lives in Chicago, and but they are all over the country. So university hospitals, we decided we needed to look at it. It was a social needs program. At our outpatient clinics at Rainbow, about 85% of our patients are on their health care is paid for by Medicaid. And so we know how our families are socioeconomically. So the social needs design program was a full-time program manager, a full-time program fellow. Then we have 24 student volunteers, and they're called advocates, and these are college students, Case students, John Carroll students, Cleveland State students. We have 2 social work interns, and we work also with our social workers at Rainbow. So Rainbow has their own cadre of social workers. And we saw them overlapping, that the UH social work, we have so much that we have to do. I mean, I'm calling social workers because a kid comes in and they've got bruises and we need to explain what's going on, or the family's having other issues. We have a lot of mental health concerns. We have families who unfortunately suffer from mental illnesses and may or may not be taking their medication, or may not be entering care the way they should. Substance abuse. Actually, while I've been here, I actually went across the street and did a consult for a almost 3-month-old who actually is from Lake County, who was positive for opioids at birth and positive for the metabolite of marijuana. And he's got bilateral cataracts, a retinal detachment, rib fractures, and a leg fracture. And of course, nobody knows what happened. And then there's the whole issue of transportation, which is huge. I mean, if you think about how our patients come to us, if my patient comes on the number 6 RTA, they get off in front of Severance Hall. They have to walk 2 blocks up the street, maybe with a stroller, maybe not, maybe with 2 kids in the snow. So I'm amazed that anybody ever comes to see me, but I have a pretty good show rate. And then health leads, what they do is they look at the commodities, they look at food, utilities, employment, housing, transportation, legal, and financial. So they had to figure out what was going on in Cleveland, and we had to help them identify. So our social needs program, we had patient populations that are screened, and the people that we screened were new OB, obstetric clinic patients, 2-month well visit babies, adolescent clinic patients, centering pregnancy, which is another program. And so then there was a workflow. They just told me I have 2 minutes. So this is what happened from February 2017 to February 2018. Eligible in that group, there were 2,961. We screened 2,515. We got a positive screen of people needing resources at 60%, and 82% of those enrolled. Now then this is what happens, and all of you who deal with social service know that this happens. People fall out. You just kind of lose them. And so 15% are in process. We had an informed patient access, meaning that they got enrolled and they got what they needed. Connected, 18%. But then we were unable to reach 42%. And that's very common for us. I mean, people's phone numbers change, their addresses change. What was important last week is not as important this week. And then the most requested needs were commodities, food, utilities, and other. And the commodities are things like diapers and formula and cribs. And then the other things were housing and employment and legal and transportation, adult education, and child-related and financial. So what's next? Health Leads is going to move out when we move downtown. As you all know, we're building a beautiful new building on 50, I think it's 59th, between Chester and Euclid. We're going to have, there'll be a bus line on Chester and one on Euclid, and then we're going to stop in front of our building. Parking is going to be free. So we're going to take it over now. It's going into Rainbow Connects, only we're going to change the name now to Rainbow Connects. They just decided that last week after I did my slides. So that's who we are, and that's what we're trying to do. And my little thing says end. I was told to do this like a TED Talk. I've never seen a TED Talk, so.
Good afternoon. I would like to recognize the co-authors of this presentation, Brianna McIntosh and Marisa Hollinshead. The Youth Risk Behavior Survey is a questionnaire which middle and high school students in Cuyahoga County school districts complete regularly. This project follows the practices described by the Centers for Disease Control and Prevention, which created the Youth Risk Behavior Survey and coordinates its completion at the state and national level. The project enjoys broad participation by county school districts so that results are considered accurate for in-school adolescents, including those that don't complete the survey. Results provide information about the opportunities and challenges that teens experience daily in the county overall and for the 6 regions which you can still see in that map. As stewards, the Prevention Research Center for Healthy Neighborhoods manages all phases of the project, from questionnaire content planning to data collection through dissemination. In addition to results tables that are posted on the center website each year and provided to school districts, the project team has worked with partners and especially our YRBS Advisory Committee to create products for use by a variety of audiences. Today I'm going to describe just one such promising example of how local data are being used by focusing on this turquoise infographic. Earlier, the advisory committee noticed that the past 12 months reports of adolescents experiencing depressive symptoms or having experienced sadness or hopelessness for 2 or more weeks in a row, such that they stopped engaging in normal activities, and past 12-month experience of suicidality were high in Cuyahoga County. This led us to an in-depth examination of our data. We created a data brief that described characteristics of students reporting these behaviors as well as associations with other risk behaviors. Our Schubert Center colleagues wrote sections on what to look for and community resources. Our advisory committee authored an accompanying letter of recommendations to address this critical emotional health need of our youth. During this process, we identified that the highest rates of depressive symptoms were being reported by students that identified as Hispanic or Latino. And through collaboration with Hispanic UMADAP and the Hispanic Alliance, we adopted a mantra: identify the issues, raise awareness, create a sense of urgency, and commit to action. And hence, this spotlight on depressive symptoms was written in English and translated into Spanish. A sense of urgency developed when we began to evaluate national data. In 2015 in the US, 3 of every 10 high school students reported that they had experienced depressive symptoms in the past year. And it was higher among Latino students. But look at what's happening in Cuyahoga County, where 2 of every 5 Hispanic Latino teens overall reported depressive symptoms, and among the Latina population, it is 3 of every 5 teens. For suicide attempts in 2015 in the United States, 1 of every 11 teenagers reported that they had attempted suicide 1 or more times in the past year. Higher among Latinas, 1 of every 7. Among the Hispanic Latino population in Cuyahoga County, male and female alike, 1 of every 5 students reported that they had attempted suicide 1 or more times in the past year. This information has been shared broadly at the state level, at conferences and task force meetings, and locally, we have been attempting our due diligence in presenting at several conferences. And the Hispanic Latino youth-focused community has been sharing the spotlight and the data brief and that information as liberally as they possibly can. In fact, today and tomorrow, the Clark-Fulton MyCom committee is holding a community forum to celebrate their change makers and to continue that mantra of raising awareness, instilling a sense of urgency, and providing information about just one example of a shared commitment to action. Through a grant obtained by Hispanic UMADAP, La Mariposa, or the Butterfly, a youth empowerment program specifically for young Latinas, has been shown to be effective, has been acquired. The staff of Hispanic UMADAP have been trained, and this program is now available after school as one program at Hispanic Youth Center. Hopes are very high that this will reach children in need. Earlier, I mentioned that this is just one example of how issues of youth well-being are being addressed through collaboration and use of YRBS data. Thank you.
All right, this is where I guess I'm going to show my age. You're all part of the Nielsen family here now as we try to collect some information from you on our online poll. We've got 5 questions. You're familiar with how this works. And so for our first question, to what extent Do you believe Cleveland is a healthy city by ensuring all of our children enjoy good physical and emotional health? And we can't get it to move up, but we will.
Here we go.
There we go. So number 1, a very healthy city for our children. Number 2, somewhat healthy city for our children. 3, not healthy enough for our kids, but striving. And 4, unhealthy for too many of our kids.
Maybe you have to vote.
Sure, okay. So our results are coming in. Again, if you're arriving, the table 10 has the URL for logging in.
Has everybody voted who's going to vote?
We'll give you another minute or so for those still logging in to vote.
Hannah, do you advance it or do I? You do?
Okay. Okay. Thank you. So we saw that 3 appeared to be the choice of the majority. Striving, but still unhealthy for many of our children. How familiar are you with the data in our county's youth risk behavior survey that Jean spoke of? 1 is very familiar. 2, I've heard of YRBS, but not sure about the data. Or 3, I'm not at all familiar with YRBS. And this one, Jean knows if I don't put 1, she's going to throw something at me because we talk about it. So we got a good mix here. Okay, a little bit longer, I think. We'll go a little bit longer. Okay, still a good mix. If you have questions, Jean certainly, I'm sure, will be around to help to give you background. Great, thank you. Moving on to, I believe it's question 3. To what extent do you agree or disagree with the following statement? While we could always do more, mostly I think our community does a lot to address the health of especially vulnerable populations like LGBT youth. You strongly agree, mildly agree, disagree, or have no opinion? So many people feel we need to do a lot more. Certainly. That was pretty clear. Okay, moving on to question 4. To what extent do you agree or disagree with the following statement? While we could always do more, mostly I think our community does a lot to address the health of especially vulnerable populations like incarcerated youth. We have some verbal opinions. We also feel free to log those. We do not want to bias the crowd among our epidemiologists here, but feel free. We have strong feelings, and that's good.
Do these ones happen after the next panel? Because they seem really relevant to what's going to happen next.
I believe those are ours. Right? Yes, I believe these are ours.
Next 3. But
Oh, yeah, well, I
You mean
think,
the next
right,
part?
but the polling is just in the middle here, yes. You are correct, sir. They are relative to all the panelists. Thank you for paying attention to the entire agenda.
We can't get these to move up.
You gotta come out of here first. You gotta come out of there, and then you should be able to do it. Now you should be able to go. You gotta go here, and let's see. Here we go. We're doing enough. Strongly agree, mildly agree, disagree, or no opinion. We clearly have a lot that agree with our expert in the audience. Thank you. Disagree. So I think moving on to I believe it's our final question. We're close to it. I understand that exposure to trauma, environmental hazards, structural racism, we've heard a lot today about structural racism. Folks, I'm sure, are familiar here with that. I thought we may need to define it, but given the number of presentations today, I think it's well understood by this group. Or other social determinants of health can impact the child's healthy development. But I'm confused about how to best use this information. It's pretty much how I feel. I'm confused, sort of how I feel. I understand how to best use this information. I don't get why social determinants matter. Those are your choices. Right, we have a lot of folks here that feel armed to use this information for purposes of action. I think that's great. Okay. I believe that's our last question. And now we'll move on to our next three panelists to continue our speed dating with our presenters. So next up, we're going to hear from Dr. Lynn Williams, a psychologist and yoga teacher at the Ohio Department of Youth Services, Cuyahoga Hills Juvenile Correction Facility, yoga meditation and mindfulness with incarcerated youth, alternative healing practices we'll hear about. Dr. Angela Chicha, Associate Professor of Psychology at Case Western, will talk about telehealth. And we'll hear from Phyllis Harris, the Executive Director of the LGBT Community Center of Cleveland, who will talk about the Prevention Warriors. And so we're excited. Prevention Warriors, I love it. So we'll hand the mic over to Dr. Williams.
Just want to start and just express a lot of gratitude for this forum. And also, I just feel like all the young people are behind me, so may my voice represent them. If you feel comfortable, gently close your eyes and just start to bring your attention to your breath. Just let yourself just be in this moment. And take a slow, deep, cleansing breath, letting the breath go through the lungs, expanding the belly, and exhaling, letting go of any stress or tension in the body. One more deep, cleansing breath, inhaling, feeling the fresh, revitalizing oxygen, exhaling, relaxing the body, and allowing yourself to fully be in this present moment. If you feel comfortable, continue to keep your eyes closed. Imagine a child that you care deeply about. They are already going through the difficulties of growing up, and now they are locked up, feeling alone and hopeless. Far away from their family and all the people they care about, they do not trust anyone. They feel fear but may not be able to show fear. They may have to lie or act with a certain kind of bravado to protect themselves. Now, imagine that we have a way to bring a sense of calm and well-being into that child's life, despite all that is going on inside and around them. Something that will fill them with a sense of hope and confidence that they can get through this, a tool for self-regulation that not only impacts the child, but all the people and the environment around him or her. Now, if your eyes are closed, you can gently open them and come back to the room. These are the youth in our detention homes and juvenile prisons. I'm at Cuyahoga Hills Juvenile Correctional Facility. Some are as young as 10 years old and can be the most challenging behaviorally and desperately need every tool that we have to help them navigate institutional life and beyond. Some have no family visits. Some have no family at all and are in county custody. Some are dealing with an absent parent who may be deceased, incarcerated, or dealing on drugs or their own mental health issues. Some are in the custody of their grandparents and worry about their failing health. Some youth are parents themselves. Managing institutional life is very difficult. Not only is their identity reduced to a number, they're told when to eat, wake up, sleep. They may not know what's happening to their case. They may be trying to avoid violence when it may be coming their way. This is hard for anyone to handle. Then put mental health and trauma issues and coping well in a locked institution is almost impossible. These are how these young people are trying to get through every day. This talk uses the term yoga, mindfulness, meditation interchangeably. The type of yoga we're talking about uses gentle movements and breath awareness and affirmations. Anyone can do, irregardless of physical ability. Here's our yoga class at Cuyahoga Hills. You don't need a special studio or fancy clothes. Everyone can experience the benefits. Here's a video of one of the youth that participated.
Last when I was 13. And I started doing yoga when I was 16. When you go to DYS or if you locked up in any containment, any contraption or anything, you have to deal with suffering. That's the biggest part. So when I was introduced to yoga, it was similar to martial arts and stepping. That's what I was doing in my school when I was younger. And you know, it calmed me in the inside and I was able to deal with my suffering. And that's what I ran to. Meditation, relaxation. Meditation, music, and you know, Dr. Williams introduced that to me, and I had no problem adapting to that and using that as a part of my combat with dealing with DYS. To this day, I still meditate. To this day, I still pray. To this day, I still wake up and do a couple salutations, you know, and I still work out and everything. And you know, that's a part of my lifestyle. I never abandoned Kung Fu, so I'll never abandon yoga.
The mainstream community is noting the benefits of meditation, and leading researchers such as Harvard are scientifically proving the emotional and physical benefits. Our very own Cleveland Clinic knows the benefits and is using yoga with children at its Center for Integrative Medicine. The U.S. Department of Education has endorsed mindfulness, and many schools are incorporating it into their curriculum. A Baltimore school replaced detention with meditation, and the result, 0 suspensions. Our community partner, Pamela Hubbard with Golden Ciphers, is using meditation and yoga in her community or center. Why? Meditation helps us be non-reactive and non-judgmental to what's going on around us, making a gap between our thoughts and increasing our ability to manage our emotions. Often we tell our youth, stop, think, and act to make better decisions. But when their neurophysiological systems are on overload, stopping and thinking is not that easy. Incorporating breath awareness makes a new model: stop, breathe, relax, then think and act. This can help with the essential skills of emotion regulation, frustration tolerance, impulse control in all of our youth. National research has found 65 to 70% of detained youth have a diagnosed mental health disorder, and at least 90% have had at least one trauma. These are the exact same numbers that we have at Cuyahoga Hills. Sadly, we cannot ignore the issue of race. African Americans are 5 times more likely to be held than whites. In 2017, Cuyahoga County had 745 juvenile felony adjudications. 84% were Black and 12% were white. Some of the youth are serious youth offenders and have adult time hanging over their head if they don't do well. In 2017, we had 64 transfers from the juvenile system straight to the adult system. After 3 years, 47% recidivism rate. Funding is very difficult. This is a picture of my program. I do an intake on the intake unit. We do a weekly class, but we don't have the funding for ongoing programs. They're often volunteer-led. The time is now. Let's give all our youth, like Andrew, this is him with his daughter, a chance at a better life for them and all the generations to come. Thank you.
I'm going to switch gears just slightly to a topic that may seem unrelated, using telehealth to increase the access to identification of developmental risk in underserved children. But I have a nice connection that many of our juveniles that are in the juvenile justice system also have a history of language learning disability or other developmental disability that goes undiagnosed, unsupported, and untreated. And often inherent in that is difficulty with self-regulation, emotion regulation, and emotional control, which the outcome of not identifying children early can be seen in our juvenile justice system and also in the educational system in terms of dropout rate and lack of completion. So there is a tie-in, but I'm just going to talk about the precursor to all that, and a chance to get these kids the help they need so that they can be successful in life, and how we can use technology to help us do that. So I'm going to just give you a brief introduction to our project, and then I want to tell you a story about Jalen. So first, our project is called INVEST, and that's the identification of neurodevelopmental disabilities in underserved children using telehealth. And the idea here is that for low-income minority children, the diagnosis of a neurodevelopmental disability tends to come several years later than it would for a child in an upper SES group. To give you an example that you've probably seen in the news, the diagnosis of autism, for example, continues to increase yearly. And in higher SES groups, this diagnostic age can be down to 2 or 3, with our low-income minority children not receiving a diagnosis till 7. So there's a huge window of opportunity missed to provide early intervention services and have this child prepared and ready to go to school, and not be in a position of potential expulsion because of an undiagnosed condition that might lead to difficult behavior. So the goals of our project were to use technology to help children access these services in their neighborhoods within a system that they trust, in this case, their pediatrician, and using a neighborhood health clinic. So we partnered with the Neon clinics, and we've been specifically working in the Huff clinic to use a 2-stage process that would allow for the identification or the risk of a neurodevelopmental disability within a well visit, so that the pediatrician is immediately notified of that risk. The child can then be screened and plugged into currently available early intervention services that the family might not be aware is needed for the child. So the goal the start age of the program is 1-year-old, and we go to 7. And our goals are to decrease the age of identification and increase engagement in early intervention programs. We have a web-based developmental risk survey followed by a telehealth screening protocol. And really this just means we're video conferencing with the family during their pediatrician visit so that they don't have to find the time, take time off work, provide transportation to go to a visit to get a full assessment if they're not sure something's going on. And also to start the conversation about developmental lag that they might not even be concerned about yet. Within our protocol, we have approximately 60% identification of risk with using the developmental risk survey that we created. And then from that, in the full screener, we have a 30% identification, which is slightly higher than the population rate. But we prefer to over-recognize than under-recognize given the historical lack of diagnosis. And then from there, they're given a referral for a full developmental workup. So the conversation has been started with the family, and hopefully there's some buy-in to understand that going to the full appointment is worth the sacrifice that it might take to get there, to then be able to get services that are already available for early intervention. So let me tell you Jalen's story. Jalen was a 4-year-old boy who went to Neon for his annual well check visit. He is currently living with his grandmother at the time of the assessment. And while they waited to see the pediatrician, they completed our developmental risk assessment, which is scored automatically. And he was identified to have risk. Now, when you asked Grandma if she was concerned at all about Jalen's development, she indicated that she had no concerns. But when she answered the developmental questions, a risk was identified. That was conveyed to the pediatrician. And then after the child's visit, unfortunately after he had his shots, but he did come back and do a video conference full screener for 30 minutes and was identified at risk. He did fail the language and the behavior portion of the screener and was showing signs of autism. And then we did refer the child to Help Me Grow, and the family, Grandma did pursue that option. Now, coming into this well-visit appointment, she had indicated no concern. She had two other children with her in tow, and they were there for a very short pediatrician appointment. But within that time, we were able to identify something that might have gone on longer without identification, have him engaged in services before the kindergarten mark, and so hopefully improved Jalen's outcome. So that is our INVEST project. We continue to work with Huff and are looking at ways that we can transform this into something more pictorially based for families that don't have the literacy level necessary to respond to the developmental survey. Thank you. Oh, I should say, sorry, I got so lost in my thought. We can use technology to address barriers within the neighborhood where the families are comfortable and have trust. And then these are the rest of our partners that have worked with us. Thank you.
Good afternoon. All right, so I get to do this, maybe do that. Which button? Okay. So I'm here to talk to you about the Prevention Warriors program. We were very excited about this program. This slide deck was prepared by some of the young people who would help us recruit other young people and would go with us to talk to folks at the library, community centers about having a program there. And so it was called the Prevention Warriors, and they named it. They also developed the logo there. And so at the center, each of the young people involved with the program has a purple sweatshirt. I have about 3 of them, and I don't know why I couldn't remember to put one on today to show you, but they had sweatshirts that say Prevention Warriors on the back and would have the logo there in the front. And so part of the process was getting them engaged in actually developing what it was the name of it, what the materials were gonna look like, and on the other side of this, we were working with we were working with the Cuyahoga County Board of Health to follow all of their guidelines around having an evidence-based curriculum, and then also choosing a curriculum that was inclusive of LGBT individuals. Most of them were not, by the way, and so we were able to work with them and to modify those curriculums to make sure that they were inclusive. One of the things that the young folks wanted to point out is this statistic: around 22 states plus the District of Columbia requires sex ed in schools. 12 of them require sex education teachers to discuss sexual orientation, and 3 of those 12 states require teachers to only impart negative information on sexual orientation to students. And so they wanted to point out that you should be shocked that yes, 3 states in the United States make LGBT youth listen to discriminatory information by their own teachers. And so some of the problems that we see from our young folks when they're talking, when they have questions about sex ed, is not necessarily getting misinformation from their peers, and they're getting either no information or they're getting judgment by the adults that they should be getting good, medically accurate information from. And so this is a huge problem that our young folks know about and want you to know about and be outraged about. So we have this partnership with the Cuyahoga County Board of Health to deliver the teen pregnancy prevention program. And some of you might know that the teen pregnancy prevention funds were cut 2 years early for funding that was awarded. And so our program officially ended or formally ended at the end of last year of December. We still have a cohort of young people who participate, and we deliver our evidence-based curriculum, and I'll say a little bit more about that. So it was really for youth ages 14 to 19. The average age of the participants were probably around 17 years old who really got into it. We did have some younger folks, but mostly around 16, 17, right when they're really getting interested and curious. I took this idea, this program. I was very excited as a nonprofit practitioner to bring the program to our organization, but also because of the fact I could diversify our funding, and even my board, to put into perspective, they thought, well, why would we have a teen pregnancy prevention program? We're the LGBT center. These are queer kids. And I said, they're kids, they're young people. So that really gave me good information about what we're dealing with in terms of people's lack of understanding about including LGBT folks. So I'm always excited to be included, to have a seat at the table, to not be an afterthought and added at the end of the program or at the end of all of the planning around the program, but at the beginning. And so we can see that this is even important for people at the LGBT Community Center as it relates to information. I wanted to point that out. So the curriculum that we used was called All For You, and we spent several months working with the Cuyahoga County Board of Health and other staff and other folks to ensure that it was LGBT inclusive. We had to follow their guidelines and had to be medically accurate, and all this official stuff that you all know about probably had to happen. And so, and one of the things that we put on here are some of the organizations that were really supportive in allowing us to come in and to deliver the program. So Lake Erie Inc., we had a great program there. Life Skills, I live in the Larchmere area, and there's a Life Skills school there, and I'm driving up Woodland, and I love seeing young people with Prevention Warriors sweatshirts on that go to that school. Cleveland Heights Public Library, Maine was excellent, and also Beachbrook. Some of the challenges is that people were uncomfortable with LGBT or talking about, the queer community, so that got difficult. Partners were tough. The program structure, it's an evidence-based sex education curriculum called All For You. The curriculum contains 9 content lessons and 5 service learning sessions, which was great for the individuals. So they had, in class, didactic type learning, hands-on projects, and then they went out into the community and they did service learning. So it was really great. Videos, music, all the things that young people love, they got to pick it. They also got chances to be peer leaders and lead up in the program. Some more of the challenges: retention. These were not captive audiences. When there are programs that are not delivered in a school setting, we can't necessarily guarantee that young people would show up. It had to be flexible. Things happen. You all, if you've done any youth program, you see how that happens. And even if an organization has promised space, there's still a challenge holding them accountable. We would show up to deliver programs, youth would show up, and then they didn't have the capacity to host us. So some of the impacts. So, this is the slide that they put together, and listen to them. I believe them. But to see youth empowered, I think now is the time, if you're paying attention to what's happening in our society. These are young people who are being missed in terms of how to make healthy choices about their sexual health. And they're being missed because if we're focused on it at all, we're missing the number of people who are identifying, young people who are identifying as non-binary, who are identifying as queer, who are identifying as pansexual. They all need this information, and they love delivering it. They love being knowledgeable, and there is a lot of misinformation. Even as smart as they are, there's a lot of ways that misinformation is delivered and transferred, and so this is very important that they have the opportunity to learn and grow and expand and then deliver that to their peers. I'm out of time. I'm sorry.
I will say, Phyllis, that the Health and Human Services felt that the component that tied, when we had the funding, the component that tied the LGBT component to the application was novel, and they thought particularly compelling. So I think that's an important note to share with the crowd. So I'm going to kick us off, and then it's going to be up to you folks, or a guy in our office, Roger Sykes, who spent some time in Atlanta. He would say it's up to y'all to jump in. So the first question, I think I'm going to offer, and it really tying together a couple pieces here. Bernie, I know you went on a listening tour with a lot of pregnant women, talked to a lot of providers as you were working in first year Cleveland in sort of the stage of understanding the best approaches and the like. And toxic stress is something we're hearing a lot about. And so as a driver for health outcomes and for related to birth outcomes. And then Lynn, listening to your presentation about meditation, I was on a plane with Congressman Tim Ryan and was reading a book, and don't get mad at me, the book is called Meditation for Fidgety Skeptics, and that would sort of fit me to a T, I suppose. But it's fascinating, and so I began digging in and learning, and even the value of a minute of meditation I'm learning is incredible to start off. The book is great. Well, he's in the book, and he said the reason he is in Congress still with some of the stressors of the partisanship is because of meditation. Because of meditation. And so I would ask, and perhaps others in the panel, this idea of novel approaches to dealing with stress. I've begun trying it, and I've been amazed at the sense of peacefulness that you can derive. But he started asking me questions, Tim Ryan, and I said, I'm only on page 5, so I can't help. But I guess I would ask the panel, those that are looking at stress as a driver, Lynn, your sense of perhaps the cross utility in dealing with toxic stress in a lot of different age ranges, a lot of different situations, pregnant women and the like. And Bernie, what do you think?
Yes.
You have to stand up, Bernie. I'm sorry, so the crowd can see.
It is correct that stress is tying into infants dying. And so we do think you have to do two things. One, we're working very closely with Birthing Beautiful Communities and Dr. Angela Bernadette. They are doing sister circles. They are doing mindfulness. They are working real hard. But what we're really cautious is that is not the long-term solution. The long-term solution is stop the structural racism that is causing the stress. So you do need short-term solutions, but we want to be really clear. Over the last 5 decades, this community has worked on changing the behavior of the expected parent. And it may be the reason why we haven't long-term decreased our infant mortality. We really want to change the behavior of the systems in addition to working with parents to be the best they can. But it is a great short-term, if you have a chance, pick up some material, but Birthing Beautiful Communities and Dr. Angela Burnett are really working in a lot of different capacities, decreasing stress, but it is a short-term solution.
Can you hear me okay? And I guess I wouldn't say for myself yoga and meditation, mindfulness as more of a short, I recognize all the different systems. However, what I've seen is the techniques, they help the person make a foundation that they can navigate these systems, and there's so many different dimensions, but I've seen it with the family stress, the kids are stressed, and just I guess working with youth, the brain doesn't stop developing until 25, and I really believe that these tools can help neural pathways, can help with all those different skills, and the legal person was talking about how kids in schools, they just by reaction just will push a teacher or something, and then they have an assault charge, and then they're wrapped up in this whole system that they can't get out of. So I would just want to put that.
Thank you. So we have, the mics are available, I believe, here. So in the back, if you do have a question, please head to a mic and ask away.
Thank you for the wonderful panel. I work in public health, and I think the manner in which I would frame it is not short-term or long-term, but primary prevention, secondary and tertiary prevention. And meditation and yoga can work at all three levels, but I really appreciated your emphasis on the need to change on the primary prevention side, the structural components of the system that creates those stresses. When those chronic stresses go away, new stresses will take their place because stress is part of life. So having yoga and meditation as an option really benefits everyone. I guess the question that I would ask is perhaps to Lolly, whether you're seeing that starting to be integrated into clinical practice at all as well.
Meditation. Ollie, I'm sorry. I think they want us to stand up when we answer. Thank you.
Okay. When this first came up, one of the reasons that I explained to parents about why we do time out with kids is that it allows the child to get themselves together. And a lot of my patients, they did not have time out. I have a little girl she's not little, she's 11 now. You're talking about autism, and she came to me, her mother brought her to me when she was 3 because she would just walk in a circle and not make eye contact. And the family told the mother, you need to spank her and make her stop that. So there's a lot of teaching that has to go on. And one of the things that I try to teach my residents is the legacy of slavery and the legacy of what it was like. So a black child who misbehaved could jeopardize the whole family. I mean, Emmett Till got killed because supposedly he whistled at a white woman. So children were spanked and given, to me, harsh punishments, but the family was concerned that, they wouldn't live to be an adult, and that you had to do this to be able to survive in the structures that they lived in. So I do a lot of things with parents. One of the things that I do is I model a lot. So I will praise the child in front of the parent. And, I'll say, now, oh, you sit there and I'm going to talk to your mom. And then I say, oh, you're doing a good job. And, I'm so sick of good job, but I say good job all the time. Good job, good job, good job, good job. And the parent gets to see that I get the response that they would like to have, but they've never seen that. I do the same thing with reading. Dr. Needleman is Dr. International Reach Out and Read. I don't know if you know, Rob Needleman over here he did the re-edit of Benjamin Spock's book. So he's Cleveland's Benjamin Spock. Benjamin Spock actually was here in Cleveland too. But he's my go-to about child behavior. But I'm looking at all these things and thinking about all these things, and a lot of what we have to do with families is we have to model. I mean, you can tell them, but it doesn't always work that way. It's better if you model to them. So when I give a child a book and I start reading the book, because many of my families, no one ever read to them, so they don't know how to read to their children. Somebody read to me every night. Either my mother or my father, and I actually preferred my mother because she would change her voice to be the different characters, and the big bad wolf said, and the little bitty hen said, and my father would just say, the big bad wolf said, and the little bitty hen said. So, but they read to me. And it's interesting because I start the book, and the child gets very focused on the book, and the parent does too, because many of them have not been read to. I don't know if you've seen, but recently some research has shown that, and we see it all the time, these kids with these little tablets and somebody's phone, their speech is delayed. The more screen time you have, the more delayed your speech. So I tell that to parents because they think that they're giving the child a treat, and what I really want them to do is talk to the child. So I don't know if all that makes sense. I would love to be a fly on the wall when my own children are in therapy because I'd love to hear what they... told the therapist about having me as a child, because I used to say to them, they're 4 years apart, and I say, I'll kill you and bury you in the backyard and make two more that look just like you, and nobody will know you're gone.
We won't tell anybody you just said that, Lolly.
And then I heard my daughter said to my son, she can't do that. She can't make two more that just look just like us, Max. They got to start out as babies, and people will know we aren't here. But I think they turned out okay. But I think when you work with families, you really have to understand where they're coming from, because I have to do that all the time. I have to say, okay, now why is this parent saying this to this child? Why are they giving them Cheetos for breakfast? Well, I probably would like to have Cheetos for breakfast too, but I just know it's not good for me. But to them, it's a treat. So a lot of it is explaining and educating. And my son and I do yoga together. I'm not really good at it. And that's one of the reasons I don't go to yoga studios, because you have all those people like you who probably, do all these things. And then they'll say, do the downward dog backwards and get up and do that. I'm like, I don't know any of that stuff. So enough.
Thank you for that stand-up routine, Lolly. That was great. Off the cuff, no less. We have other questions.
Thank you, guys. This panel was so amazing. And I say that because I see the compassion and just the care to just want to do more. But what I say is, and just to add a little and then ask the question, is I tell people we learn from each other. We think people know what we know, but they don't know if you haven't been taught. And a lot of people taught me as I grew and developed. And so being a mother of 8, being a community advocate, I tell people you make time for what you really want. If you want to do it, you do it. If not, somebody has to entice you to understand the importance of the value of it. And for the lady that did the LGBT, I'm currently writing a book about that. I'm an author. I have 12 books of everything I went through in life as a child and working with children to keep them off the street. And the book is My Life, My Pain, My Story. It's about 15 youth that are actually some of them are adults, some of them are younger, that are dealing with how they had to survive through being gay, and how they learned de-escalation, how to overcome, and how to make life expand. And I think I just want to share with you that so that for the future, I want us to connect. So when those books are ready, they get to hear and talk to another kid and listen in that book to say, this is me, and how I can still survive, and how I'm still somebody regardless of my sexuality. So
I think I definitely appreciate that. I think. Oh, I'm sorry.
Sorry.
I think people think because there is, like today I posted an article by Janelle Monáe, who is a popular, I don't know, she's just amazing. And so she came out recently as pansexual. And I sometimes have to look up the definitions to be able to understand it, because it's evolving fast. And but it was such a testament to young people. Young people begin to click like, over and over. Oh, I'm on That's what I really want to do. That's my alter ego. But anyway, so young people, really need to see those role models. And so we think that because someone like Janelle Monáe, who's pretty popular, can come out, because there's a lot more in the media where LGBT people are out, and it's still not enough. I've had a really rough week this week. Just coming, just like there's always so much work. I've gotten we had a team meeting on Tuesday, and in the last 3 weeks, I've gotten, the phone calls have gotten to me and the emails have gotten to me, 11-year-olds who are dealing with, understanding their identity and not choosing the binary boy, girl, male, female, and looking for all three. So it was a guidance counselor, it was a parent, and it was an actual 11-year-old, but they were all talking about 11-year-olds, which I thought was interesting. And so I'm referring out to the Cleveland Clinic, and I'm referring out to UH just announced a new services for LGBTQ families and folks. So every time someone gets curious or interested in being able to show role models of adults, healthy adults who have, who are out, who are proud, who are living their lives, who don't want, what their sexual orientation or their gender identity to be the first thing that you know about them necessarily. I'd rather that, I wish I was a rap star or something, but that they see role models. And so that's very helpful, very useful. And like I said before, really thinking, losing your heteronormative lens about how we have relationships, how we have sex, our gender expression, it's happening. So if you really are conscious about and really want to be good caregivers, if you want to increase your professional skills, learn about the community, and make friends with people like me so that you can learn cheap.
But what we're missing, I always have residents doing things for me. So one of my residents who's a gay male, I told him we need a resource of support groups for gay and lesbian and transgender children, because most of them are on the west side and they're far away and my patients can't get there. And I do have parents who are trying very hard to be supportive of their kids, but they need supports themselves. So one of the things I'd like to try to put some time with you is we need more resources on east of the river and at places where people can get to on bus lines and that sort of thing.
Okay. I have a question for Jean. I know, Jean, there's sometimes a bit of a challenge as you face in recruiting schools for a number of reasons. Can you talk about some of the barriers and perhaps ways you've been able to surmount barriers with challenges reaching schools to gain participation, given all their challenges they face and competing priorities?
Well, the importance of relationships, I think, is paramount. We have been working in Cuyahoga County to administer this survey since 2001. And I think that we can't underestimate the value of us, our team, going to schools repeatedly, whether principals change, whether guidance counselors change. Clearly teachers and students do change as well, but we are persistent. We have a huge base of support by community members and organizations, local foundations, the County Board of Health, the City Health Department, the schools themselves realize that the value of this data comes back to them tenfold as they're able to analyze, to review it and understand it as it impacts the success of our students academically, because we know that health and academics are associated.
Thank you.
So half the respondents said that they knew about the YRBS, but about half said that they didn't know about it or didn't know how to get access to it. So I'm wondering, how do those people get access to YRBS data?
If we knew. It says it is. But I think I have a bad mojo with technology. What do you think? Is this one working? Okay. How do you get access? Well, how about #Cuyahoga YRBS? That's a Twitter handle, I guess. Or you could go to our website, which is prchn.org, and there you can find all of the data tables that have been created since 2001. You can, how else? Oh, Bree and Marisa have a couple of cards about how to pass it around. You know, that's just such a difficult question. Help.
Okay. All right. We have a question here. Okay.
Angela, does your screening look for risk of lead exposure in the kids? And if so, what resources do you refer those families to?
Yeah. What we were looking at is just, we were only looking at developmental milestones, not the cause of the lag in development. And so we have play as a proxy for cognition. We have speech, receptive and expressive language, reading readiness, and social emotional and mental health questions. And so we don't look for what's causing that. We're just looking for the red flags. And currently we are all volunteer. All our efforts are volunteer only. So, we could add more things, with funding. So.
Okay, great.
Just a shameless plug.
Okay, great. Thank you. Okay, so we have about 3 minutes left. And so, Jean, you talked about a Twitter handle. So I think what we're going to do is ask folks I'm going to ask you, what is your tweet in the last, your verbal tweet here in the last few minutes? Share with us, each of you. You can choose any order, whoever maybe feels ready, spontaneous. Give us your tweet.
Our tweet in response to...
What's your takeaway message for the crowd?
Wow, it's about being included. I love it. I think it's needed. So thank you.
Technology can improve children's health.
My teacher says one leg is action and one leg is meditation, and we need both.
She's so smart.
I would say
That's a retweet. You have to say tweet.
knowledge and stories are powerful, powerful impulses and information.
Your children are going to pick your nursing home.
It's hard to go after that one. I guess for me is racism is alive and well today. Act now.
And before I hand the microphone back to Jill, my tweet is vote for the Health and Human Services Levy.
Okay, well, we can't thank this panel enough. This was just such a breadth and fabulous amount of perspective and information, so thank you very much. So now what happens is that you can stay in your seats or go away and come back quickly. We're going to raise the walls again, and we're going to go into a closing session. And the closing session will end with a really fabulous session of grandmothers and grandchildren, so an intergenerational group doing some African drumming for us, followed by a networking hour when we all have a chance to talk with each other a little bit more, trade cards, trade ideas, and have a chance to talk to some of these fabulous people who've taken their time today to share this knowledge with us. So thank you so much.